Let's hear the story.
All right.
A lot of anticipation here.
Right, that's a little bit too much. I have my disclosure slide went by. The other disclosure is hopefully you haven't seen this presented before. If you have, I apologize. But at least in the aortic space, we're looking for something funny to present. So this is titled, Don't Try This at Home. This is a treatment of subaortic stenosis with TAVR. So we have a very active adult congenital program at Emory Hospital. So we get sent a lot of patients that need unique solutions. This one was 34 years old. She had Shown syndrome with some congenital mitral stenosis, had 2 previous sternotomy. One was a tissue mitral, and she's currently with a mechanical mitral valve. And her family that was bringing her in noticed that she was getting progressively more fatigued, decreased activity. They were watching the gradient through her subaortic membrane. It was 30, then it went to 40, and now the mean gradient was 65, and she was really starting to slow down. She was not a great surgical candidate in that she had Downs and a lot of cognitive dysfunction, didn't know if she was going to live another 5 or 10 years without developing significant Alzheimer's. So they deferred surgical intervention, referred her for catheter therapy. So here's the problem, and I just show a few things here. Let's see, is there a pointer? Maybe. But I think you see where we drew the annular plane. Then the subvalvular stenosis is nice, like a napkin ring. And then a little further down, that white area you see on the right, that's the mechanical mitral valve coming in place. We did the annular area was 338, knowing that she would be grossly oversized with the 23. But our proposal here would be to try and anchor the S3 valve, much like we do in homographs and so forth, where you have a short area of conduit to try and exclude the subaortic stenosis and also anchor it some at the valve level. We decided to go slightly oversized because, this thing keeps progressing. All right, so here was the second problem we encountered. Let me go forward here. She had small iliac vessels, and the family said, by the way, you can't leave her with any drains. We want short or no ICU stay. We want the family be in the ICU because of her cognitive problems, that she would get very anxious and start ripping out even her IVs, which we had to cover in purple tape so she would not. Her abdominal aorta was 8 millimeters. The distance from IVC to aorta was a little over 10. So we thought that probably transcable would be our best option as far as giving the family what they wanted. So I don't want to belabor this slide because Adam is going to belabor it here in a minute or at least later in the session, but I think all of you are aware of how this works. This is the initial angiogram. You can see the pigtail is squashed in there, so it's a sub 10 millimeter abdominal aorta. And this was the angiogram ahead of time from the LEO projection with the mechanical mitral valve working. The crossing was uncomplicated. I wrote here, because this is kind of an older slide, distance dictates the PDA closure device, but in fact that's what most centers are using for closure regardless of distance, and we used the 14 French expandable Edwards sheath since we were using a 23 S3. So we decided to inflate a balloon. This was a 20 millimeter balloon, and 2 things that we noticed: one, where the waist was on the REO, and then if you look at the LEO, you could see that the waist, if you further inflate it, expands, and it's stop flow as well. And the valve is still working with the balloon inflated, which was an important point, because we did not want to get into a situation where we implanted it and one of the tilting discs stopped working. So here's where we placed it, down low. We were hoping for the skirt to shorten towards the top. In fact, this kind of shortened towards the middle because of the point of contact. You can see it in 2 views. But the mitral valve is working in both. And then with final angiography, you see on the REO an excellent result. In the LEO, if you look really closely, you can still see her native valve working above it. And her gradient dropped from 65 to 15 mean, which was a win. And all the 15 was coming at the level of her native bicuspid aortic valve. The closure was interesting because it's such a small aorta. You can see us opening the PDA here. The hat's getting kind of squashed, not opening all the way, taking up a lot of the aorta. So we went ahead and inflated a balloon in the abdominal aorta. The gradient, before we inflated the balloon across the PDA device and the abdominal aorta, was about 20. We made 2 inflations, deployed the device, as you can see, and the final gradient in the abdominal aorta was about 5. So, interesting case. This patient was discharged on postoperative date 1, no transfusions. Her 30-day follow-up, in fact, we have 1-year follow-up now, shows no change in gradient. This is a woman that is on Coumadin, so that's what you would probably expect. Good proof of concept type of case for stenting of the LVOT with the transcatheter heart valve, and feasibility of transcaval approach for next-day discharge in small abdominal aortas. Thanks.
So 2 related questions. That's really cool.
Yeah.
Certainly a unique case and a great outcome. But one of your post-implant aortogram images showed a leaflet just laying flat over the top of the frame, which appeared not to be causing a gradient at the time. I suppose it depends on how fibrotic it gets. And I was thinking all along, why not use a core valve to be more likely to sort of cover the whole area?
Yeah, I think that's a good point. We have deployed core valve in the LVOT, and you have to be a little bit cautious here because we've seen recoil, stent recoil, and actually it looks like one of those jumping things for the kids that collapses open, and we've had problems with gradients afterwards. So I think you have to be a little bit cautious when you go for core valve. Also realize when you do push the S3 and the diamonds start to elongate a lot, you have a lot of radial force, and placing it where you want is I think a little bit easier. Their repositionability gives you multiple options. If we had time, we would have shown that case also with the core valve in the LVOT, but I've seen reports where it's worked, and I've seen cases where it hasn't, so word of caution. Jeff.
Hey, is this a bailout solution for an LVOT obstruction after transcatheter replacement?
So interesting thought. The problem, of course, you're saying bailout for the mitral, Jeff, is if the anterior leaflet goes in front. I think you'd have to put the valve very low, and in fact, the case that we had the core valve look like this is that specific case that I'm talking about. So I would be very careful. We think, ablating the septum, and particularly in our smaller group, that getting rid of the anterior leaflet is probably the way to go because of the way the valve tilts so much into the septum. And sometimes it's really hard even to get in. Once you've got a valve in the mitral position, it's very hard to get a valve in the aortic position. So it almost makes sense to do it in the other direction. Adam, you have a comment that you want to?
Well, no, there are anecdotal cases of actually a pulmonary stent or something in the ability to do that. The only difference in the TMVR situation is that we have the interaction with the TMVR valve. You crush that valve with that kind of stuff. But actually, it would work as a bailout. And this is proof of concept that even if you did it, if you were worried about trapping the leaflets and causing wide open guy, you just put the saving valve in and allow these leaflets to work. But you just have the issue with the interaction with the cage.
Anecdotally, there are cases that have worked, and apparently cases that have not.
Have not worked yet.
So there's one that does work, and never really.
We have one, and I think I don't think you were there, Adam. We had one where we started off. We did a valve in MAC, ended up with LVOT obstruction. It wasn't so horrible that we couldn't get the patient off the table. We took her to the ICU, waited 2 days, brought her back, did the core valve. It looked okay, but we had a pretty significant leak around the core valve, put a sapien inside of it, got rid of the paravalvular aortic leak, deformed the mitral and started having leak around the mitral, went back and put another mitral, and then kind of V-kissing, and the patient had,
the Lotus for that so they could all live together.
it looked like a mess. Four valves later, the patient, expired in 48 hours. So I think we have to be a little bit cautious how they share the spaces.